Hello, this is Muneir from BGB College of Pharmacy. Today I'm about to talk about a very important topic in chemotherapy. Today I'm about to talk about the chemotherapy of tuberculosis. As we all know, the tuberculosis is one of the diseases that affect the 20% of the world population. So let me start with the definition of the tuberculosis. We know tuberculosis is defined as a chronic granulomatous disease caused by Mycobacterium tuberculosis. So it affects like a 20% of the total world population. It's mostly in developing countries. In India, about 5,000 people develop the disease every day. And about 37 lakh people die in India every year due to tuberculosis. So it is a very dangerous disease. So we need to take care of and to know how this disease is spread and the prevention from this disease and how to get the treatment of this disease. First of all, this disease is spread through the air. You know, when people have active TB in their lungs, cough, spit or sneeze. So the people with the latent TB do not spread disease. So the people will be at the high risk of tuberculosis are the people with the HIV and the people who smoke. So let me tell you how to get prevention from this disease. First of all, the vaccination with Bacillus camlite. This will prevent from the getting the effect of tuberculosis. So let me explain the treatment of the tuberculosis and the drug used for the treatment of tuberculosis by the following. If we talk about the drug used in tuberculosis, we got two types of drug used in tuberculosis: first line drugs and second line drugs. Just let me introduce them in general. So in the first line drug, we got isoniazid, rifampicin, pyrazinamide, ethambutol, streptomycin. Second line drug, we got ethanamide, thiacetazone, para-aminosalicylic acid, amikacin, capromycin, cycloserine, ciprofloxacin, rifabutin, kanamycin, rifabutin, fluoroquinolone. This all are the drug used in treatment of tuberculosis. First line drug are superior in efficacy to second line drug. Most patients can be treated successfully with this drug. So let me explain it to you. In the first line drug used for the treatment of tuberculosis, we have isoniazid, which is shown by INH. So we know isoniazid is the most effective and cheapest primary anti-tubercular drug. Isoniazid is effective both in acidic and alkaline medium. It is a tuberculocidal for rapidly multiplying basally but static for receding basally. We know isoniazid destroy intracellular bacilli as it is freely penetrate into the cell. For example, we have tubercle bacilli in macrophages. Basally multiplying in the cell of the cavities. This is effective against both intra and extracellular organisms, and develop if it used alone, it develop resistance to it. So as soon as it should be used in combination with other drug to avoid the resistance. So if you talk about the general mechanism action of tuberculosis drug, here as soon as inhibit the synthesis of mycolic acid, which are important component of mycobacterial cell wall. The cell wall of mycobacteria differs from other bacteria in having large amount of mycolic acid, which form essential component of mycobacterial cell wall. INH, a drug, freely enter the mycobacteria and convert it to an active form by an enzyme catalase peroxidase. The enzyme catalase peroxidase present in the mycobacteria. This active form covalently binds certain enzyme and thereby inhibit mycolic acid system. So I'm showing here the summary about the mechanism action of the pharmacokinetics of INH, or what the body do to INH. So it is completely absorbed orally. It penetrates all tissues, tubercular cavities, fluid, necrotic tissue, gaseous material, and CSF. It multiplies it by acetylation, and this is genetically determined. Patient can be fast or slow acetylation depending on the genetic inheritance. The half time in slow acetylator is 3 to 4 hours, while in fast acetylator it is only 1 hour. Peripheral neuropathy is more common in slow acetylator, while hepatotoxicity is more likely in fast acetylator. If INH is given once weekly in fast acetylator, adequate therapeutic concentration may not be attained. Metabolites of INH are excreted in urine. The adverse effect or the side effect of an INH, we have peripheral neuritis, or we call it peripheral neuropathy. It is a condition that results when nerves that carry message to and from the brain and spinal cord from and to the rest of the body are damaged. So, due to interference with the utilization and increased excretion of pyridoxine, it is seen in higher doses with an incidence of 10 to 20% and uncommon with therapeutic doses. We have the second adverse effect is hepatitis. It is another major adverse effect, more common in alcoholic and in elderly. If hepatitis is mild, INH may be continued, but in a small percentage of people or a small percentage of patients, INH can cause hepatic necrosis with anorexia, nausea, fatal. In such patient with the first sign of hepatic necrosis, INH should be withdrawn because INH can cause CNS toxicity, including psychosis and seizures. So we have the second drug is rifampicin. We call it rifampin. It's a semi-synthetic derivative of rifamycin. An antibiotic obtained from Streptomyces mediterranei. The other rifamycin are rifabutin and rifampicin. Rifampicin is bactericidal to mycolic tuberculosis and mycolic leprosy. And a typical mycobacteria, it is also inhibit most gram-positive and gram-negative bacteria like Staph aureus, E. coli, and Legionella. So the antitubercular action of rifampicin, like we said, is highly effective tuberculocidal and is the only drug that acts on both intra and extracellular organisms and is effective against tubercular bacilli resistance to other drugs. It is called a sterilizing agent. If used alone, resistance. The mechanism action of rifampicin, it binds to the beta subunit of the DNA-dependent RNA polymerase and inhibit RNA synthesis in the bacteria. It is bactericidal in therapeutic concentration. Rifampicin cannot bind human RNA polymerase and therefore selectively destroy the bacteria. Like we show here in the fig, rifampicin bind to DNA-dependent RNA polymerase, then inhibit the RNA synthesis, and then causes cell wall, and then it is bactericidal. Resistance due to genetic mutation in DNA and RNA polymerase result in produced binding of rifampicin to RNA polymerase. So the pharmacokinetics of rifampicin, it is well absorbed and has good tissue penetrability, reaches gaseous material cavities, macrophages, and CSF. The side effect of rifampicin or the adverse effect of rifampicin, we have the first one is the hepatotoxicity. The second one, gastrointestinal disturbance, flu-like syndrome. The fourth one, we have a CNS symptoms, including headache, drowsiness, dizziness. The fifth one, we have hypersensitivity. The sixth one is staining of secretions. The uses of rifampicin, it's used for treatment of tuberculosis and typical mycobacterial infection. So rifampicin 600 mg daily is given in a combination with other anti-tuberculosis drugs is 100 mg twice weekly. So it's used also for treatment of leprosy and prophylaxis, influenza, and meningitis in close contact, particularly children, 20 mg per kg per day for 4 days. So also it is used for the resistant staphylococcal infection. Also it is used for tuberculosis. The second line drug. So we know this part of drug are generally less effective and more toxic when compared to the first line drug. They are toxic and they are used only if the organism is resistant to the first line drug. So for example, we have thiacetazone, ethionamide, we have para-aminosalicylic acid, amikacin, cycloserine, fluoroquinolone, linezolid. The way to treat the tuberculosis, the tuberculosis is one of the most difficult infections to cure. The properties of mycobacteria like slow division, development of resistance, ability to remain as precise for a year, and intracellular location of bacilli have enhanced the problem. So the gaseous material make it difficult for the drug to reach. The need for long-term treatment, drug toxicity, cost, and therapy, poor patient complaint have all added to further complicate the problem. But with the availability of effective drug, most patients can now be treated as outpatient. So a combination of a drug is used in tuberculosis for some reason, to delay the development of resistance, or to reduce the toxicity, and to shorten the course of treatment. So majority of cases are sensitive to first-line drug. Initial treatment should be intensive and include drugs that have maximum effect. So, good patient compliance and course of therapy should be considered. So, the chemotherapy is given in 2 phases. First phase is initial intensive phase of 1 to 3 months. Duration aimed at killing as many bacilli as possible. Second phase is continuation phase, to destroy the dormant or parasitic duration will be like 4 to 9 months. Resistant tuberculosis. If sputum remain positive after 6 months of treatment, organisms are likely to be resistant. Such patients should be treated with 4 to 5 drugs, of which 3 are first-line drugs, and treatment is continued for at least 1 year after the sputum become negative. Resistance may be one or multiple drugs. As per World Health Organization, a multi-drug resistant strain is one that is at least resistant to ionized and rifampicin. Extensively drug-resistant tuberculosis, XDR-TB, is resistant to almost all second-line drugs like amikacin,
capromycin and kanamycin resistance could develop due to inadequate treatment, irregular supply of drug, or poor compliance. Impaired host defense in AIDS patients also contribute to resistance. Cases are Resistant cases are more difficult to treat and require more vigorous and longer period of treatment. The patient should be hospitalized or maybe should be hospitalized or isolated to prevent the spread of resistance strain to others, including healthcare workers. So when you talk about the TB in HIV patients, due to depressed immunity or the low immunity the body got, as patients are at higher risk, like 30, in the range of 25 to 30 times of contracting tuberculosis. So AIDS patients are likely to have more severe and rapidly progressing tuberculosis. Adverse effects to anti-tubercular drugs are more common in AIDS patients. They should be given more vigorous and supervised chemotherapy as per the guideline of DOT. IN plus R plus S plus Z for 2 months, followed by INH plus R for 7 months.